Anytime you have a patient with scoliosis, the important thing is to pick the surgery for their symptoms. You don't just want to treat the scoliosis. If you do that, you're only treating an X-ray. For her, the scoliosis was something she had lived with for a very long time. The scoliosis back pain was something she had lived with for a long time. And at 80 years old, with a mild lung problem, she wasn't really thinking about going through a big surgery to correct the scoliosis. I really didn't think that was necessarily the right thing for her either. But what I did think may give her some relief was a surgery to relieve the pressure on the nerve roots. So Lisa walked into my office with a primary complaint of having bad low back pain. Lisa had had scoliosis for years. She had it since she was a kid. They had told her throughout the years it was too bad to do any surgery on. So she was pretty used to suffering with a lot of back pain. What was starting to change for her though was over the last couple years, the back pain was starting to get worse and radiate lower. Before, when she was having pain like sort of more at the level of her stomach, she was now noticing that the back pain was almost like at the top of her butt, if not lower. The other thing she noticed is it was stopping her from walking, whereas before she could walk through the back pain. Now, as she walked, it was almost impossible. The pain would get so bad that she would have to sit down. Now, she did get complete relief with sitting down, which was a clue for me in terms of what I thought was possibly going on. Now, the other thing to know about Lisa is she was 80 years old, pretty healthy otherwise though. So, she doesn't have any diabetes. She has some mild COPD. Other than that, she really had no heart problems. So generally, she was doing pretty well for being 80. Now, she did have pretty bad osteoporosis though, which she was getting treated with her primary care doctor. She had been on medications for this for a while. I started by giving Lisa a physical exam. I saw that her posture was off. She was leaning forward. She had a pretty obvious curvature to the spine. On her exam as well, though, she didn't really have any nerve problems. So her legs were relatively strong. Her reflexes were not concerning. So overall, she had a pretty normal neurologic exam. However, I was suspicious from her symptoms that she maybe was starting to get something in the spine that she hadn't had before. I had her get an MRI, and here's what we found. Looking at her x-rays, I saw that Lisa had had a pretty substantial scoliosis, which I knew she was going to have. You can see right here, she has this big curve over to the left, and then a big curve over to the right. Now, interestingly, even though she has a big curve, it's balanced. So if we think about where her head's at, it's relatively centered over the middle of her pelvis. Adult patients that have big curves, but that are relatively balanced, a lot of times these patients go on living like that for years and they never really even realize how bad their scoliosis is. At 80 years old, I wasn't really thinking about a big operation for scoliosis, and she wasn't really thinking about that either. Unfortunately though, all the treatments she had tried weren't really helping. The back pain was getting worse and she wasn't getting any relief from her medications anymore. Physical therapy wasn't really working. She was trying epidural injections, but that wasn't helping too much either. She had even had a spinal cord stimulator placed at one point. But again, she wasn't having relief of her pain, and this pain was also somewhat different. So let me show you what we found on the MRI. We saw that Lisa was getting some worsening compression of the nerve roots at the bottom of her spine. Now, what this is called is spinal stenosis. Stenosis just refers to narrowing. For Lisa, the narrowing was happening at the lower part of the spine, which is called the lumbar spine. So she had lumbar spinal stenosis. Lumbar spinal stenosis by itself just refers to narrowing of the space that the nerve roots go down. But when it gets bad enough and it starts causing compression of the nerve roots, and the compression is bad enough that patients start to get symptoms, at that point you may consider having a surgery for it. And that's what I talked to Lisa about. What I noticed was different, or what she noticed was different, was the level of the pain, meaning not how bad it was, but where it was. Where the pain before was more, again, like in the waist region, and it was something she could walk through, now the pain was a lot lower. What that told me was that The scoliosis pain that Lisa had was probably not what was driving the symptoms she was having now. It wasn't the pain that was from the arthritis-related scoliosis. It wasn't the pain that was related to her curvature. It was pain from the nerve compression. And the fact that she told me it was different really gave me a big tip-off. I talked to Lisa about a surgery. She wasn't really thinking about going through a big surgery to correct the scoliosis. I really didn't think that was necessarily the right thing for her either. But what I did think may give her some relief was a surgery to relieve the pressure on the nerve roots. This kind of surgery is called a lumbar decompression or lumbar laminectomy. The thing with Lisa, though, is we were going to need to do a lumbar decompression in a region that was already somewhat unstable. It was a region where, because of the scoliosis, the bones were starting to move out of place. I was concerned that if we only did a lumbar decompression or a laminectomy, that could potentially further destabilize the segment, and the segment could get worse and create even more back pain, or the nerve compression could come back because the segment wasn't stable. Let me show you what we did instead. On Lisa's CT scan, I found out that not only was this segment, the L4-5 segment, a little bit crooked, or had a little bit of what we call a listhesis, but it was also stuck between two parts of her spine that had fused. Almost the entirety of Lisa's upper lumbar spine had fused itself together just from the degeneration over time. It was like a door that had gotten so rusty, it had rusted itself shut. The same thing had happened at the bottom. This segment was stuck right between two areas of Lisa's spine that had fused together. I knew we had to get rid of the compression on the nerve roots, but we also had to deal with the fact that this segment was in a very high stress area. What we did for Lisa was do a 1-level lumbar fusion with T-LIFs. T-LIFs stand for transforaminal lumbar interbody fusion. Transforaminal means we get to the disc space by going through the foramen. Lumbar means in the lumbar or lower part of the spine. Interbody means that we're between two vertebral bodies, or we're in the disc space. And then fusion means we're putting in cages and bone graft in order to fuse the spine together between the disc spaces. What we did for her is we used navigation, which is a technology that allows us to be a little more precise with our screw placement, to place the screws in her spine, considering how curved and abnormal her anatomy was. After we placed the screws, we did the decompression of the nerve roots, so the laminectomy. So we took off all the, what's called the ligamentum, we took off the bone spurs that was causing pressure on Lisa's nerve roots. Next, we placed 2 interbody spacers, we call them. So interbody means we place them between the vertebral bodies. These ones I used were made of titanium. So I used 2 for her to distribute the stresses a little bit better, considering how much osteoporosis she had. The other thing we actually did was we used cement that we placed through the screws. Now, this is not a technique that I use very often because it increases the strength of the screws, but sometimes it can create problems as well. So it's really something I only like to do if I think it's absolutely necessary. But for her, considering how much stress we were gonna feel, or how much stress that segment was gonna feel, I thought that cementing the screws was a reasonable thing to do. What we actually did as well was we placed 3 screws on the right and only 2 on the left. The reason we did this is that way I didn't create what's called a stress riser. Now, a stress riser can happen when you have a very stiff part and then sort of a not so stiff part above. So I was worried about just placing 2 screws and then having the rest of her spine be her normal weak osteoporotic bone. So instead, I tried to place 1 screw to kind of give it a little more of a transition as it went from the really stiff cemented screws into a little less stiff, and then finally into her own bone. Lisa felt better almost immediately. In fact, I was honestly kind of surprised, but she really bounced back quickly from this operation. She noticed a difference in her pain like post-op day 1. Which is great. I can't say it's typical. For most people, it takes a little longer than that. But she's a year out now. All the screws and rods, everything is holding up. The bone graft seems to be taken. She has her regular back pain, the kind of back pain she lived for 50 years of her life, but that pain that was causing her the problem, the pain that was keeping her from walking, that nerve pain, that's a lot better.